Support Services at the Cayman Islands Health Services Authority. He will be discussing the health benefits of hyperbariatric oxygen therapy. Now, I understand it's not limited to just the treatment of decompression sickness in divers, and I'm told that I should personally as well be listening to what Dr. Douglas has to say. I'm sure you will find it interesting and informative as well. Let's welcome Dr. Douglas.
Thank you very much. Thank you. Good evening, everyone. Just want to start off by saying that I was brought up by my grandmother in Jamaica, who was paralyzed from ever since I've known her, from ever since I've known myself. In fact, that was what motivated me to become a doctor, and this with the hope that I would find some restorative treatment for her walking. On arrival in the Cayman Islands in 2006, I believe it was the first day, a diver presented to the emergency room. He presented paraplegic, and I simplify that he just couldn't walk. He was unable to void, so he was to be catheterized. And it was a young man. I can see he was terrified, because below the waist and a young man, that's not something to be taken lightly. The patient was treated with hyperbaric oxygen therapy, and that was the first time I was exposed to this. And I'm not sure if Dr. Fiona Robertson is here. She was the one that introduced me to it. And with several treatments, the gentleman was able to walk. We were able to remove his catheter, and he was subsequently discharged asymptomatic. This experience further motivated me. Of course, I was thinking about grandmother who had died, to undertake further studies in barometric medicine. So I did hybrid courses, both for underwater medicine and hyperbaric medicine in South Africa, requiring me to attend face-to-face 25 times. This was the first step, I would say, bridging the gap of my ignorance at the time surrounding hyperbaric medicine and the patient. So there are benefits of hyperbaric oxygen therapy, and I won't elaborate on decompression sickness because it's quite clear, and it's a very complex topic, hyperbaric medicine, I must say, because I don't want to be going into this bubble medicine and how much hydrostatic bubbles and all of that. That's not the point here. I just want you to be familiar with it and what we are able to do with it. So I'll start off with a definition because some person doesn't know. I remember a colleague came to me and said, listen, I have someone and that needs to go in the chamber. Will he just stick his foot in the chamber, So we want you to understand that it's not like that. So an overview of this presentation entails what a definition of hyperbaric oxygen therapy. We look at the pharmacological effects, because once you understand the pharmacological effects, you can see the indications. And we'll use these pharmacological effects for the current indications, and you will see myriads of indications, but there are only 14 indications that are approved. And I'll tell you what you can do, why is it that it's said that it can do other things. And yes, you will get some form of good outcome, but they will only be transient. So just bear that in mind. We look at the current benefits, and we look at our useful tool, which is called TCOM, transcutaneous oximetry monitoring, and then we'll conclude with a summary. So hyperbaric oxygen therapy, and listen carefully, it is the breathing of near 100% oxygen. This is done intermittently. It's not done continuously. If you do that continuously, this will result in something called oxygen toxicity, and this may result in seizures. So when you're in the chamber, you're only going to breathe 100% oxygen at intervals. And this is done under high pressure. Now we are at 1 atmosphere, but in a chamber, you go like 2 atmosphere and so on, depending on what you're treating. If you're treating something like gas gangrene, you need to go quite deep, 3 atmosphere and so on. So it serves as a primary as well as an adjunctive or complementary therapy for a diverse range of medical conditions. Now back to what my colleagues thought, you just stick your leg inside of the chamber. No, you have to go inside of the chamber. So there are 2 types, pretty much. You have the monoplace, which accommodates 1 person, and then you have the multiplace. So yeah, as you can see, the monoplace here, it's, the issue with that, it's claustrophobia, so a lot of persons not going to go inside it. So you go inside the chamber as a patient, and it's operated by an individual outside of the chamber that controls the gas so that you can breathe the oxygen intermittently and so on. So you take breaks, as stated, that you cannot breathe the oxygen continuously, otherwise it will result in oxygen toxicity and seizures. Major drawbacks, claustrophobia. I know some persons are able to go inside, but it's really a big problem for some persons. But we do have the multiplace chambers, and that you can treat multiple patients at a time. And that chamber, you have an attendant inside that attends to the patients. That's a gentleman there in gray. These are the patients. And there is an operator outside of the chamber that basically controls the depth of the chamber and the gas that is being administered. Again, please remember that you cannot breathe oxygen continuously, otherwise it will result in oxygen toxicity and seizures. Now we have tables or protocols, and this depends on what we are treating. For example, the one that's been displayed now, typically this is a treatment protocol that we use for wounds, problem wounds like diabetic wounds. So you're here first, you start increasing the depth, takes about 5 minutes, and then you breathe oxygen for 30 minutes. Then you take an air break for 5 minutes. This is how it goes, 30 minutes oxygen you breathe, 5 minutes you take a break, 20 minutes you breathe oxygen, and then you go up back. And this is pretty much about 100 minutes that we utilize this protocol to treat wounds like diabetic ulcers and so on. But there are other regimes, other protocols. For example, if you have gas gangrene, you need to go like, instead of 2.4, you may have to go 3 atmosphere, and of course that's a deeper depth. So let's look at the pharmacological effects, why this is helpful, okay? And so let me just sort of exclude the last one because that's mainly dealing with decompression sickness and arterial gas embolism, which we won't elaborate on in this presentation. 1, hyperoxygenation, and that's simple. You're just getting a lot of oxygen, that's what it means. That's what it's capable of doing. Vasoconstriction, that's simple. You have your blood vessel dislumen and you're subjected to the hyperbaric oxygen therapy. It constricts the vessels, and you will see the benefits of that as we go along. Neovascularization, and as you know, doctors like to use these big words, but it's just new vessels formation, right? You just form new vessels, that's all it means. And then altered cellular function, it changes the function, and we'll speak more about that. But pressure and gas gradient, we won't go in all those bubbles and so on. So we'll leave that for the doctors. Now, these are the 14 indications based on the Hyperbaric Oxygen Therapy Committee. It's important. air gas embolism, decompression sickness, those two are out of the scope of this presentation. And I won't say much, and I won't say on all of these. But Clostridium myositis, like your gas gangrenes, your crush injuries, your carbon monoxide poison, severe anemia, yes, severe anemia, intracranial abscesses, which I'll pause a bit on because I know the neurosurgeon is going to say, why are you treating abscesses in the hyperbaric oxygen chamber? But you can just imagine you have multiple seedlings, like 30 different seedlings of abscesses within your brain. Nobody going to touch me with a knife with that. By the time they're finished, more damages than you can't drain that. So it's best for you to give a trial of antibiotics and subject you to the chamber. Necrotizing soft tissue infections, refractory osteomyelitis, delayed radiation injury, osteoradionecrosis for instance, compromised grafts and flaps. Sometimes the plastic surgeon may graft something and it's just rejecting the hyperbaric, subjecting individuals to hyperbaric oxygen therapy may be helpful. Burns, very important. Central retinal artery occlusion, CREAR, we'll see a bit on that, and idiopathic sudden neural hearing loss. So these are the 14 indications, but you will see that other persons may want to use it. Say, for instance, for fibromyalgia, you will get some benefit, but perhaps in the next 2-3 months, you will just go back to baseline. So that's not really one of the 14 indications. All right, so let's start on hyperoxygenation. We are talking about the pharmacological effects now. So most cells in the body, right, if you are subjected to less than 30 millimeters of mercury, of oxygen tension there, then it's not going to do anything. They are dormant, they're sleeping, you need more. But with hyperbaric oxygen therapy, all hypoxic cells, they become active. And what happens? You're going to increase the neutrophil, the phagocytic killing, and those terms, those are the ones that are responsible for fighting infection in the body, and that's why it's used to treat like diabetic wounds and so on. Your fibroblastic activity and your cellular activity, example, your osteoblasts. So you can see where osteoblasts, those are the tiny cells that when you're having issues with like osteomyelitis and so on. So you have increased osteoblastic activities taking place when you're subjected to hyperbaric oxygen therapy. And because, and we can leverage on hyperoxygenation by treating decompression sickness, arterial gas compression, carbon monoxide poisoning, crush injuries, and compromised graft and flaps, and severe blood loss. Now, I want you to pay particular attention to this slide. The top, which is colored red, it's hemoglobin. And the green is plasma. We know that blood consists of a solid part and a liquid part. I'm not talking now about the white blood cells. I'm talking about the red one now. Now, if you note on the left side, here, that is at 1 atmosphere. That's where we are right now. This is 2 atmospheres that you can achieve when you are in the chamber. So look and see what happens with hemoglobin. This concept is very easy to understand. And I would like you to understand this one. So if you have 100 mils of hemoglobin and you're at sea level right now, just as you are, it's saturated with 19 mils of oxygen. Okay? Now, if you are subjected to the hyperbaric oxygen therapy, that same 100 mil of hemoglobin will only be saturated with 20 mils of oxygen. So you can see it just moves from 19 to 20, which is almost nothing. And this is why people say you can live without blood. And we'll get there. Now look what happens with plasma, which is the liquid part of the blood. For 100 mils of plasma, it's saturated with 0.3 mils of oxygen. But when you are subjected to 2 atmospheres, it moves from 0.3 to 4.3. So this is 15 times more. You see, 15 times more oxygen carrying capacity takes place by subjecting an individual to the chamber compared to almost the same with hemoglobin. All right, so why is this of any benefit? Let's see. Not moving. Okay, right. So a paper as late as I would say early as 1960s by Boehm and colleagues, they concluded that life was possible without blood. Listen carefully. What these guys did, I don't think we do these things anymore, but it's important. They exsanguinated piglets. So in other words, they drained the blood from the pigs, such that the hemoglobin came down as low as 0.4 to 0.6 grams per deciliter. So that is just not compatible with life. The blood was replaced by normal saline. And we spoke about the whole plasma. And the pigs were ventilated and subjected to hyperbaric oxygen therapy. The piglets were found to survive, and after reinfusion, they live happily ever after. So this is actually the experiment.
An experiment, in fact,
right? And this
shows
is
that
real.
life without blood is possible under hyperbaric conditions. Pigs breathing pure oxygen at 3 eta are totally exsanguinated. The volume of fluid in their circulatory system is maintained. The absence of erythrocytes makes the pig look very pale, but the oxygen supply is adequate. After reinfusion with their own blood, the pig lived happily ever after.
But the only thing, don't jerk these pigs, okay? You can't do that, please. All right. So a 39-year-old female with placental rupture, and the gynecologist will clearly tell you what that is. That's something they hate to hear, because if your placenta rupture, let me tell you, it's a nightmare. You lose a lot of blood, right? Reported hemoglobin was 1.9, right? And you know you need hemoglobin like, how much? 9 or so on Earth. But normal is like 10, 11, 12, right? So this lady developed multi-system failure, DIC, disseminated intravascular coagulation, bilateral deep vein thrombosis. So it was really bad, right? But the lady, she was a Jehovah's Witness. And I'm telling you, she's not going to take the blood, right? And that precluded her from being transfused. So combination therapy with hyperbaric oxygen therapy was considered, and the patient was referred for treatment. She received ventilator support, dialysis, and remember, intravenous iron takes probably about a month to start kicking in, so she get all of that. So what happened, this lady was subjected twice per day to hyperbaric oxygen therapy, so she had enough oxygen to carry her throughout the day, while they infuse intravenous iron, EPO, and so on. And she was discharged after day 29 to rehab and home soon after. So I just want to let you know that it is quite possible to survive temporarily without blood, okay? All right, Hart and colleagues, in 1987, they published a paper, Intermittent Hyperbaric Oxygen Therapy Used in 26 subjects, of which 18 survived, 8 died. Of course, they had decorticate, decerebrate neurological status. The hemoglobin ranged between 4.7 and 3.8 grams per deciliter. So this is actually happening. I've seen it happen myself, but it is it is possible, but it requires a multidisciplinary approach. So in general, it's not someone that comes in with an hemoglobin of 6. It must be severe, and it's indicated on the grounds of refusing blood, or I'm not sure if you have seen patients, you just can't cross-match them. They may be O positive, and you have O positive blood, and it's just rejecting. So those are some of the candidates that we want to utilize this treatment modality. As I stated, you need to maximize the medical treatment. You need the anesthetist to ventilate the patient and so on. So life is possible without blood, temporarily. Thank you. All right, so let's move on now to the vasoconstrictive property of hyperbaric oxygen therapy. If you look here, this is what the normal lumen of a vessel looks like. If it's dilated, it's wide. And if it's constricted, this is how it looks. Now, when you're subjected to hyperbaric oxygen therapy, this is what happens. Why this is of any benefit? So, when you subject someone to the hyperbaric oxygen therapy, there's a 20% decrease in regional blood flow. Okay? But because of the ability of plasma to transport the oxygen, there is actually a net effect of a greater compensation, and at the same time a decreased inflammation without hypoxia. So just imagine if you're subjected to burns and you wait a few hours, you're just going to get very swollen, very edematous. So if you get them and you stick them in the chamber pretty much right away, this is what's going to happen. You're going to have this vasoconstriction taking place. The leakiness, because the walls tend to get a little like it's thicker, the leakiness of all that fluid outside and swelling will not occur, right? So burns is really a very good kit. I've done a few here at HSA. It's really, the results are really fabulous. When you catch them early. Don't come a day after or hours after. It has to be right there, right in time, right? Now, this is a 23-year-old female with facial burns from flaming gasoline and tar. And as you can see the progress here, this is 12 hours after she was burned, 36 hours, and this is just after 2 treatments. And after 6 treatments, this is how she looked, and shortly before discharge. And this is what she's looking like today. A friend of mine tried proposing to her, but she was taken, right? Now, ladies, don't get yourself burned just to try and get the results like this, all right? Right. Right. It's right. But this is real. This happened. Okay. All right, let's move on. This is also utilizing the whole vasoconstrictive property, but it's a collaborative effort. This is not just something done by the chamber. We need a team. 30-year-old male with 60% total body surface area burn and inhalation injuries, subsequent treatment, and with hyperbaric oxygen therapy, debridement, and so on. And you can see the end result at F there shows that the outcome was quite good. Neovascularization, new vessels formation. Now, we heard quite a bit on subjecting cancer patients to radiations and so on, right? And we know that nowadays we are getting good results. But in general, radiation therapy it results in a chronic progressive injury pattern. The vessels are destroyed, the cells are destroyed, the area becomes hypoxic. So the vessels being destroyed, that's hypovascular, the cells hypocellular, and the area hypoxic. So you're not getting much oxygen there. So all aspects, and the area becomes fibrotic. So all aspects are addressed by hyperbaric oxygen therapy except for fibrosis. Oh boy, I'm telling you, the animals. Okay, Marx and colleagues in the 1960s, they decided that they're going to radiate some rabbits, right? Just like you're treating cancer. And then they look at the angiogenic property, that is the new vessel formation when they are subjected to hyperbaric oxygen therapy, when they are subjected to just breathing oxygen by face mask, and when they just breathe air. And it's found that those that were subjected to hyperbaric oxygen therapy, the result was 8 to 9 times vascular density compared to those just breathing oxygen by the face mask and those breathing air. So we do know that. In fact, I spoke to a lady today, and she stated that Dr. Fiona actually did quite a good job, because that person stated they had a cancer of the neck, and the results was quite amazing. So this is what it's like. The wound may not heal, but you do the proper treatment, it will subsequently result in good outcome. So altered cellular function, team. So there's increased collagen deposition and maturation, bactericidal and endotoxin suppression. That's basically you just fighting infections. It has synergistic effect on antibiotics, and some antibiotics which I'll introduce you to. I believe it's the next slide. The ultimate result is better wound healing. I'm sure we were all in medical school. We all know this graph, that you increase the oxygen tension, the percentage, as you increase it, the percentage of Staph aureus, which is a bacteria, you can see the exponential killing. If it's 0, it's 0. And if you reach as far as 150, then you'll get almost 75% being killed. And this can only be achieved within the hyperbaric oxygen chamber. So it potentiates the following antibiotics, some of which we don't use here anymore, but the sulfonamides, the clindamycin, aminoglycosides, penicillin, and rifampicin. So problem wounds, like some of the diabetic wounds, are what we leverage on with respect to altered cellular function, radiation necrosis, also gas gangrene, and refractory osteomyelitis. There's some osteomyelitis just not being healed the traditional way, and subjecting patients to the chamber would be beneficial. All right, let's move on to carbon monoxide poisoning. I think we have seen our fair share here in the Cayman Islands. It happens from time to time. But the effects of carbon monoxide, and people associate carbon monoxide, of course, if you're in an enclosed area and the muffler from the car is running, or a generator has been running in an enclosed area, and so on. So we have seen our fair share here. Patients are coming hypoxic, and it has cardiac effects and it has neurological effects. So I want you to understand that. So I'm not going to bore you with the whole mechanism of carbon monoxide poisoning, but what happens is that it takes out the oxygen from the hemoglobin and something called carboxyhemoglobin, and it doesn't release that to this tissue, and then you result in hypoxia and suffocation and death in summary. With cardiac effect, so if you have an underlying cardiac problem and you're exposed to carbon monoxide, This may result in dysrhythmias, right? In other words, your heart just going chaotic, and that can result in death. And those who have underlying angina, in other words, a blockage that is stable, you will start getting angina symptoms. You may start getting angina symptoms if you are exposed to carbon monoxide poisoning. So the neurological effects is varied, and that's based on the duration and concentration of exposure, the ventilation, and your heart rate. Now, who do you subject to hyperbaric oxygen therapy when it comes on to carbon monoxide poisoning? First, I want to say there's a huge discrepancy within the literature between the symptomatology and the level of the carboxyhemoglobin. As far back as in the 30s, they had this, layout that less than 10%, you have minimal symptoms. If you have 10 to 20% carboxyhemoglobin within your blood, you're going to have this tightness across the forehead. If it's 30 to 40%, you're going to have severe headache and generalized weakness and so on. And as you can see, as it increases like greater than 60% of carboxyhemoglobin within the blood, then this may result in cardiac and respiratory depression. This is really nicely laid out, but some patients are found to have with less than 10% and they're unconscious. This is what's happening. And some patients with levels greater than 50% only have mild symptoms. So who do we subject to the chamber? So these are the indications. There are some patients with less than 10%. So obviously, if you come in comatose, we want to get you in the chamber. Neurological impairment, any form of neurological impairment, we want to subject you to the chamber. Any cardiovascular involvement, like ischemia, chest pain, don't waste time, get you in the chamber. If the level is greater than 40%, get you in the chamber. And if you're pregnant with 20%, because let me tell you, the fetal, the placenta and the fetal hemoglobin, oh my God, it loves it, and your fetus is just going to die. So we need to subject you to the chamber. And if you're getting treatment, even with recurring symptoms for like 3 weeks, you need to go into the chamber. And if you're not resolving, because sometimes you come into the ER, we start to just on giving you oxygen from the wall. And if you're not resolving within 6 hours, then we want to subject you to treatment within the chamber. Gas gangrene, it still exists. If you miss it, it's something that gives you a nightmare. I've seen a couple being missed, resulting in amputation of young 17, 18-year-old. It's not something nice. It's rapid progressive, non-pyogenic, so don't expect to see any purulent thing, right? And it's with profound toxemia. You're just sick, right? With swelling, massive tissue death, and it comes with variable gas production. A lot of times the physicians say, okay, I didn't feel any crepitation, so it's not gas gangrene. They palpate. Normally you want to palpate and you get the crepitation. That's what in the medical text. And it's far misleading, right? Because that may be late or it may not occur at all. As you can see, most Clostridium infection, which is, in most cases, this is what we believe, the cause. They do not produce appreciable amount of gas, and most gas-producing infections are not Clostridium. So don't be fooled. You have to have a high index of suspicion. It comes from time to time, and it will haunt you if you miss it, trust me. It's not as strict anaerobes. That's your Clostridium, and it may grow freely on oxygen tension. And it's restricted even up to 70 millimeter. So don't just say it's an anaerobe and it's not happening, right? It can grow, even having oxygen at a level of 70 millimeter mercury. So the big problem is that it's not a normal tissue, it's not necrotic tissue, it's rapidly advanced in phlegmona and continues to production of this big guy here, the alpha toxin. It's important for you to seize this alpha toxin. It's death, right? It's very important. This is the killer. And this can be achieved in the hyperbaric chamber, subjecting patients to high levels of hyperbaric oxygen therapy at depths of like 3 atmosphere. Early signs, anorexia and apprehension. You see, I'm going through this because I'm telling you, you don't want to miss this, right? Incubation period, like 48 hours, but as less as a few hours. Pain out of proportion. This is a big one. The patient just keep on saying, doctor, my leg, something, and they're just crying, and you examine it, and you're not finding anything. This is a big one. The pain is just out of proportion. Something is wrong. By the time you find out what's happening, it's an amputation. Tachycardia, diaphoresis, and grain pallor, fever, mental changes, skin tense, bronze, tender, brown with water discharge, blue, black, bulle. Classically, you may find those, but it may not. Crepitations may be late. Later, you have the whole necrosis, hemolysis, and that's really late. Patient ending up on dialysis, hemolytic anemia, hematuria, acute renal failure. Anybody seen it before? No? Yeah. Not nice. Yeah. Thank you. So, with the chamber, you want to preserve the viable tissues, you differentiate the viable tissues from the non-viable one. The chamber is able to, all the alpha toxin, that's the big guy, you may be able to demarcate where you need to amputate, because it makes a big difference whether you go above knee or below knee. So it's important that you get the patient in the chamber, give them the antibiotics, and it will actually demarcate, and you say, listen, this is where we need to make the amputation site. Unfortunately, that's what it leads up to some of the time. Now, with gas gangrene, just with hyperbaric oxygen therapy alone, the mortality rate is 90%. So the chamber treatment alone doesn't work. With surgery alone, 90% mortality. So surgeons just collaborate with and a team effort to really get good outcome. It's not just cutting this patient. With antibiotics alone, 50% mortality. Surgery and antibiotics, 30% mortality. But if you combine all three, you can see where you gain from this. It's just 5% mortality. So gas gangrene, combination therapy, hyperbaric oxygen therapy, surgery, and antibiotics. I'll leave this with you. Good judgment comes from experience. Experience comes from bad judgment. Please don't. No, I'm telling you. I think I probably have about 2 or 3 in my. It still haunts me. Don't miss it. Yeah, I'm telling you. It's not nice to have a 17, 18-year-old, amputated because of something that we miss. Central retinal artery occlusion. I'll go through this quickly. You usually you have it's a medical emergency. It's painless, and it's usually unilateral blindness, and it's mostly incomplete occlusion, and it leads to irreversible blindness if it's untreated. The visual varies between counting fingers, light perception in 90%, and fundoscopy. If you're lucky, you may be able to see this cherry red spot. That's what they taught us in medical school, but I've never lucky to see it. You have seen it, Doc? I'm never lucky to see it. Right? But you have to have an high index of suspicion. This slide here, not to complicate things, but the central retinal artery is here. As you can see, it's a branch of the ophthalmic artery. But the point here is that if the blockage is here, there's no point in you trying to salvage the patient in the chamber, because this will result in total blindness. And it actually works for this here, which is coming from this one here. So the mainstream is blocked. No point. Not going to go into the physics of it, but it's a temporizing measure, the hyperbaric oxygen therapy, while cannulation takes place, and you eventually will, it's possible that you will gain sight from that, gain back your full sight. I'm mindful of the time. Okay. Now, as you know, physicians, their main tool is a stethoscope, right? Although sometimes they don't use it like for sometimes 3 months, but you walk with it every day, right? I'm telling you, it's true. Yeah, it's just a thing. You just no, it's true. And sometimes you're just leaving somewhere, even leaving to the bathroom. Where's my stethoscope? And you're not going to use it, right? But it's true, right? And the surgeons, the main tool is scalpel. You know that, right? So the hyperbaric physician, the main tool is the TCOM, transcutaneous oximetry monitoring. So this device, so we walk with this one, right? So this device consists of a monitor, and it consists of a probe, right? So what you do, you put the probes across the wound, above and below, and then you measure to see if the oxygen perfusion within the limb. Now, I'm going to tell you, if you don't remember anything I said today, just remember this, please. Hyperbaric oxygen therapy is not like raising Lazarus from the dead. If the limb is dead, it's not going to work, right? I'm telling you, and that's why some surgeons say, listen, I tried it and it didn't work, but guess what? The limb is dead in the first place, right? So it's not going to work, right? So measuring it and getting the appropriate value, the suitability of the patient, to see if the patient is suitable to be subjected to the chamber is important. Sometimes, of course, we don't have all these equipment, and it's worth giving a trial, but it's important for you to know that it may not work because the patient was not suitable in the first place, okay? So it's a cost-effective means. It's non-invasive. It measures the oxygen across the wound, the perfusion, and you can use it also to determine your amputation site if needed. So I won't dwell a lot on that. I'm mindful of time. But the point here is that for healthy individuals, for instance, you know that the value there is like 50 millimeter mercury, and I won't bore you with numbers here. For diabetics, it may be less, with less than 40 millimeter mercury, you know you're going to have impaired wound healing. And for non-diabetics, it's less than 35, you're going to have impaired wound healing. So you sort of get the gist, is that you really have to have some numbers, and you translate those numbers as to whether or not the patient is suitable for the chamber. Now, with appropriate selection of the right patient, you are able to get the outcome, to get this outcome here. So this was a diabetic patient referred for hyperbaric oxygen therapy with a Wagner grade 3. Don't worry what the Wagner grade 3 is about. Diabetic foot ulcer, which was non-healing after 1 year. And the patient was scheduled for amputation the following day. But the gentleman said, listen, doc, just do anything. And the surgeon reluctantly referred the patient for hyperbaric oxygen therapy. And after 3 weeks, 26 treatment, this is how the wound looked. And after 50 completed treatment, this is how the gentleman turned out. So there are definite benefits there. We have to bridge the gaps as physicians and let the patient know exactly that we do have some benefits with hyperbaric oxygen, using hyperbaric oxygen therapy. Of course, like everything else, there are complications. So you may have complications. You have to equalize. So it may result in what we call barotrauma, trauma of your ears. Imagine it's when you're descending from an aircraft and so on, and you kind of get that sensation sometimes, and especially if you're having a respiratory tract infection. It may result in pneumothorax. That's very rare, and that's why we want to check the patient's their suitability before we even put them in the chamber, because sometimes what happens, chronic smokers, they have what you call bullaes, these blebs on their lungs, and you subject them to the pressure. You just rupture their lung. You can get also what you call a transient myopia. In other words, you get a transient short-sightedness, but this usually goes away, you know. And yeah, there are some other complications that may occur, but they are rare. All right. So in summary, hyperbaric oxygen therapy is far more than diving, and I didn't go into the whole diving aspect of it. It's an important adjunct or combination therapy for a number of conditions, some of which I've outlined. There are some more that I didn't say much about. Proper evaluation is needed for appropriate selection of patients. We use our TCOM to do that in some instances. And I beg you, don't miss gas gangrene, please. Thank you.